What happens is we see a patient for 30 minutes a year, maybe an hour a year, but their health takes place in the other 5,700 hours they're awake. And we're not even part of that. And so most people are kind of navigating their health on their own most of the time.
But what keeps it stuck then? Because we have technology is there,
Yeah,
but
right.
why don't we use the technology, or rather, what is there something in the incentive structure that's
There is something in the incentive structure. And the incentive structure, again, goes back a long time. And we just don't have aligned incentives for health. We have aligned incentives to have more surgeries. We have aligned incentives to, basically do episodic disease treatment.
Hey, welcome back to Women Disrupting Tech, and thank you for tuning in to episode 163. My name is Dirkjan Hupkes, and this is the podcast that closes the funding gap in venture capital by amplifying the stories of female founders and their investors. So here's a question for you. Why does healthcare pay more to treat sickness than to prevent it? And why is it quickly becoming unaffordable? Those are questions I got from my recent conversations on this podcast, so I started wondering what a healthy healthcare system would look like. And in today's episode, you'll get the answer from a surprising place, the United States. My guest in this episode is Dr. Robin Blackstone. Dr. Robin Blackstone is a surgeon, academic, and healthcare executive who has experienced firsthand how the current system is built for episodic disease treatment. But she also noticed how much the system could gain from focusing on prevention instead. That experience led her to design Health 4.0, a new healthcare system that starts with health as an expectation, not a luxury. By listening to our conversation, you'll learn what the origins of the current system are and how they trace back to a time when we still had to learn a lot about treatments and about what being healthy really means. Why housing, social class, and trust in the system together determine roughly 80% of health outcomes, and how technologies like AI can be used to act as a catalyst for better health for all, not just the 1% who can afford it anyway. Plus, you'll find out how governance plays a key role in designing the right incentives for all participants and why working with AI is a bit like doing improv. If you're expecting this to be a boring episode, you're in for a surprise. Dr. Blackstone's enthusiasm and curiosity, combined with the many anecdotes and practical examples she has collected over the course of her career, make this a conversation that never bores. So when you're ready to discover how Health 4.0 can transform healthcare for real health equity, here's my conversation with Dr. Robin Blackstone. Dr. Robin Blackstone, good morning to you. Good to have you. Welcome to Women Disrupting Tech. Question I always ask at the start is how you got into your current role, current position, and in your case as a healthcare innovator.
Well, thank you, Dirkjan, for having me on the program. I'm excited to be here. I think it's time for women to disrupt tech, so good timing.
Yeah.
Got a lot of up and coming women going into this field. I think that there was a time when I became a surgeon that I recognized that most of what we were doing was systems.
Mm-hmm.
When we had a tough outcome, it wasn't about the people in the room or their intent. It was about the structure, about something that broke in there.
Mm-hmm.
And when I started looking at the healthcare system, I realized the same thing was true. That the structure itself in the United States is set up to rescue people, and we rescue people very well.
Mm-hmm.
But it really wasn't set up for health. And so, most of my career I've spent doing that, trying to figure out how to fix broken things. So
Mhm.
here I was, doing it again.
Yeah. So you trained, I think, as a surgeon. Uh, I think at the time that there were not that many people and not that many women in doing this training. In
Yeah.
fact, when we spoke, you even mentioned a friend of yours who didn't complete her medical training because she couldn't stand the cutting part of it.
Right. Right. That's true.
Um,
Yeah, those times were interesting for me. Culturally, the discipline had evolved around mostly being done by men, as many professions were. I mean, at
mhm,
that time, most of the doctors were men. Um, what I learned through that, though, was that if you really focused on what your job was to do,
mhm,
which was to learn to be a surgeon, which is a very complicated dance. It not only involves, unbelievable amounts of processing information, of interacting with a person in a super personal way,
mhm,
but also providing a team environment that can deliver a specific outcome. And, you had to be very resilient in those days. You know, um, One thing that I was really struck by, though, was
mhm,
I don't ever remember walking into a room to see a patient, and when I walked out, I felt they had confidence that I could do what I needed to do for them.
mhm,
And through the years of being a surgeon and treating thousands of people and, educating other young people about it, I found that, there's some definite positives in being female in
mhm,
that. And one of them is we have empathy, you know?
mhm,
It's it's like a little flame, and when you blow on it, it starts to become more and more a part of the way people interact.
mhm,
And you can teach that to a young junior resident regardless of their gender,
mhm,
and they become extraordinary surgeons because they can not only make hard decisions in the moment, they not only understand the system that they're in, but then they can reach to that place where they're compelled to give more, to do more. So, as I started through this journey and started teaching and leading programs and things like that, I just always have tried to connect the dots between the system I'm working in, the people that are in the system, and the tools and mindset that we have. But I'm kind of by my nature someone who really looks at how things can be better.
mhm,
How do I impact things for the better?
mhm.
What effort do I need to make personally? And that's really driven me to what we're doing today. You know, we have to change our healthcare system. It's not serving most of the people in the United States very well. So, you know, I looked around and I was kind of waiting, for one of the disciples to come down and start doing something, but
Yeah.
everyone's kind of talking around it. And then all of a sudden, in the midst of this, we have this explosion of technology
Mhm,
and such a opportunity to change the system in that because it gives us some of the missing pieces, but it has to be governed. And so that's a part that not very many people in my field really have the expertise to do, actually.
is that something that isn't part of the training, the
No,
governance?
no, no. Governance, we always have looked to the outside in a lot of ways for
Mhm,
governance. Um, we have we have laws that create a certain situation. In the United States, every single state is like its own insurance environment. It's completely different many times than everything around them. So if you move from one state to another, your entire healthcare system, what's provided or not, can radically change. So if you're a mother in
Mhm.
Massachusetts with an autistic child and you move from there to Texas, everything that was set up around getting that kid moving forward
Mhm.
and being able to be what they can be is not gonna happen. So that system is difficult. We also don't cover millions of people. They don't have any effective healthcare. And again, this is not on any individual. I
Mhm.
can't imagine any politician or leader of a health company, I can't imagine them really wanting it to be this way. But I think that they have cards and they're trying to figure out how to rearrange the deck chairs on the Titanic, but it's still going down,
Yeah.
right? It's still not gonna be floating. So, we have to get together, we have to back up, and we have to fix that.
Yeah, but and is the solution then, just to jump a bit in terms of timeline, is the solution then more a centralized thing or still decentralized?
Mm,
Because one of the things that strikes me in the US is that it's like you said, if you move from one state to the other, it's a different insurance landscape in terms of coverage.
mhm.
But is the solution then something that is centralized or from
So,
because
yeah, that's this is you've hit on, like, the $1,000,000 debate, right,
Mhm.
here in the country. We have about half of the maybe not quite half, 40% of the population is covered by something called employee health.
Mhm.
So you get your healthcare through your employer.
Yeah.
And then we've got all these other healthcare systems. So the Congress has their own healthcare system. Federal employees have their own healthcare system. There's not they themselves are different. Um, People that work for a huge company, like a big banking company like JP Morgan Chase,
Mhm.
it's the number 2 profit and loss entry is healthcare for any major company in this country. And in the last few years, what's happened is the employee has had pay more and more
Mhm.
for the same coverage. And that number now is about $27,000 a year in this country, of which the employee pays about 6,000, which, if you're making a couple $100,000, it's still a substantial thing.
Mhm.
But if you're making 50,000, how do you how do you afford that? Right?
Mhm.
Like you're not going to be able to afford that and send your kids to school, right? Like, so there's trade-offs that get made both
Yeah.
in health maintenance and good health, as well as in the decision making that a family has to make.
Yeah.
So I think this is just an outdated system. What happened was after World War I think it was, the inflation rate in the United States just went bonkers. It was
Mhm.
so high. And because of that, they froze wages. So there was no incentive to recruit individuals to a company because the wage was frozen. So what they started doing was offering healthcare as a benefit. That's how
Ah,
we got here. That's how long a story that is.
so
And
that's going
so,
back to the 1920s then
yeah,
indeed.
it's going back to, like, World War I. And
Yeah.
so that situation is what created this. In addition, we have a number of institutions in the United
Yeah.
States, that have been that believed that basically all physicians should be able to be solo entrepreneurs. They should be able to have their own practice,
Mhm.
charge whatever they would. It was very much the idea that they were trying to create a market,
Mhm.
but the market's it's not really a market, it's too constrained. So it really has none of the characteristics of a free market. And what happens is that in those days, the body of information that we had at our disposal to help people was
Mhm.
so small. You could fit it in a thimble in the size of a large building right now. compared to what we know today. And that knowledge has been rapidly accelerating. I think it doubles. The last count was a couple years ago, every 70 days, every 70 days. So there's no human that can keep up with that data, can understand it, can know when the data's good and when it's not, because we're not trained as statisticians, right?
No.
And so what happens is we see a patient for 30 minutes a year, maybe an hour a year, but their health takes place in the other 5,700 hours they're awake. And we're not even part of that. So that model is not sustainable or advisable. And so most people are kind of navigating their health on their own most of the time.
Yeah. But what keeps it stuck then? Is that a matter of, because we have, technology is there,
Yeah,
but why
right.
don't we use the technology, or rather, what is there something in the incentive structure that is?
There is something in the incentive structure. And the incentive structure, again, goes back a long time. And we just don't have aligned incentives for health. We have aligned incentives to have more surgeries. We have aligned incentives to, basically do episodic disease treatment.
Yeah.
And you really see that clearly in what's happened with the obesity situation, which is an area that I've spent a lot of time in. Um, we had a time back in the early 2000s where our system of delivering bariatric surgery was not adequate. It was all one-offs, you know? And we had a lot of deaths. I mean, it was like 1 in 200 people were dying after bariatric surgery at that time. So a group of us in our society got together and we said, we need to change this. We need to have a system. We need to have standards. And so we were able, with the College of Surgeons, to create that system. And we put it in place. And the last data reckoning was that we were at about 1 in 1,000 deaths. So tremendous impact from that program. It's called MBSIQIP.
Yeah.
And what happened is we tested the idea of aligning incentives, for positive. And bariatric surgery became, I think, the highest percent was about 1.7% of the people that were affected. It's still surgery. There's still risk, right?
Yeah.
And so then we realized that the surgeries kind of worked through the mechanism of GLP-1s, of creating excess GLP.
Yeah.
That and some other work that was being done in the labs led to the invention of GLP-1 drugs, which have been now on the market for 10 plus years or longer. So they're usable. And now we see that they're starting to create an inflection in the rise in obesity, which is great news. And for certain individuals, they're really a good answer. So in surgery, we have 40%, almost 50% less surgery last year than the year before.
Just because the medication is available.
And so as you create a system where you start to move upstream from rescue to proactive treatment and prevention, ideally you create health benefit that ripples through the system, right?
Yeah.
The person affected has a more productive life. They're more able to take more part with their family and everything. They have less risk of diabetes and things downstream. That's a big effect. And I believe that if you look across the breadth of medicine, you will see that is going to be duplicatable in many, many, many fields. Just addressing obesity is huge. But once you start getting these aligned incentives and you pay for health and continuity, you pay for prevention and outcomes, and you're measuring continuously the data So
Yeah.
you understand risk early, very early, what I call in the trajectory of
Yeah.
health. You personalize care, you're
Yeah.
tailoring your preventions and your treatments. And, you know, you recognize that those social determinants, where you live, what you eat, what your housing's like, how you're
Yeah.
able to move, what your family's like, and you have trust in that system, then really you're going to elevate the whole system. We could do that in the United States, and it would fundamentally change how we work with people and their future in
Mhm.
health. But it also can have a big impact on other systems that are struggling with the friction in the system, you know? And so I have a lot of hope that we can deliver not not the kind of AI that, you know, increases productivity, but the kind of AI that can deliver health. That's worth doing.
Yeah, absolutely is. Um, so I was wondering, can we double click on the social determinants part? Because you and I talked about it before we started recording.
Okay.
And I think that's very important also to understand as part of the discussion about what is not helping in healthcare. You said something along the lines of that social and yeah,
Structural.
structural. I see the situation where you're in terms of housing, in terms of where you live, your social
Right.
class, your trust in the system. That makes up for 80% of health outcomes.
It's a large number.
Yeah, how does that work? How what's the relationship there?
What's the relationship? Well, the data for this has been developed by a group of people led by Nico Pronk, who's the CEO at Health Partners, and his colleagues Ross Arena and Colin Woodard. And
Hmm.
Colin was the one who really defined in the United States what cultural groups had arisen there based on the migration patterns from the original,
No?
settling of the United States.
Yeah.
And interestingly, the native population in the United States, the Native American tribal lands, have the worst health outcomes of any group in the United States, and it's pretty profound difference. And there's a whole story about that with the Pima Indians, who I knew really, really well.
Hmm.
Um, they lived in downstream of a big river,
Hmm.
Colorado River, and when that river got dammed up upstream, they couldn't maintain crops. They ended up being what had been a really thriving community and really impactful, gracious, great farms, great food sources just evaporated. And that really caused an increase in obesity among them and an increase in diabetes. And so
How?
um, it was obesity and diabetes are very closely
Hmm.
related. And when certain populations that have obesity have really, really terrible diabetes. And that's what has happened in that group of people.
Yeah.
And I remember
But
in
I was
Phoenix.
more wondering about the relationship between them, let's say, being well off because they couldn't feed themselves, and the obesity part. Because I
Yeah,
think that's also it's a matter of food.
right. Food has a lot to do with this, and that's really what I think Nico and their data has shown
Mhm.
is that relationship is very strong. And so when the real key here is in Health 4.0, which we'll talk about, but when you're trying to deliver a better system of health, you have to look into deeply what those cultural factors are and what those environmental factors are, they're going to be more important to the production of healthy outcomes than biology will be.
Yeah.
And so that's a big deal. We've focused a lot on biology, and we for the most part understand it better. But the other parts, the system parts, the architecture of
Yeah.
the system, we've really done nothing about. And that's one of the reasons we continue to have really bad outcomes here, you know.
And how is the system then set up in such a way that both the people themselves, but also not the people who govern them and who provide healthcare, are actually going to fix this?
Yeah.
Because
It's hard. I mean, it's hard. And even though many of us who've studied AI know that AI has roots that are 25 years old or more, right? But the kind of AI we have now with, the different large language models, this type of AI is different because it allows us to have a very personalized approach to medicine, to the environment, and the social determinants and structural determinants of health. It can include all of that in the analysis of people. It can help people with all of these little things that add up to be big. The system they live in, their ability to work and exercise, the kind of food that they have, it's
okay, so it's
it's
because
really going to be the differentiator, I think, in the end, that intelligence layer, because it's easily accessible.
and because what I'm hearing you say is because the technology is better and more powerful, it can actually do better analysis on a big bulk of data, which was previously not possible.
Right, right. And it also should make all of our systems of health stronger, because both the person, the human, I call him human health ally, the physician, the nurse practitioner, all of that group of people that's trying to help the human principle, the person whose life it is, do better. Then you have what I call Dr. AI, or this intelligence layer that connects you and helps you have health in all of the hours of your waking life, not just in the 30 minutes that you get to see one of those guys. And their role also expands in a way and becomes more meaningful because they know more about what are the things that are driving your health, and they can help you with better strategies and better decision making. And so a lot of our work's going to be really defining that new interaction. And we've gone through the typical stages where, when you find magic, right, you're like, okay, what is this? And we've said it's not as accurate, it hallucinates and all that, but that era is passing. But making it accountable and understanding the governance piece of AI for health is absolutely crucial thing to be doing now. And we're lucky because there's some people leading that discussion around the world, which will be helpful.
So one thing I still want to touch on, so the technology is there, clearly. People are starting to adopt it. I speak to founders all the time who have maybe ambient listening AI who can then helps doctor do the admin, so doctors can actually listen to the patient in theoretically, at least in the 30 minutes that they see them. But there's still a problem getting that into the healthcare system as a whole.
There is.
Why do you think that is?
Well, let's go back on the ambient listener, the ambient AI that's being implemented. One of the things that that's just come out is because it listens to every single word,
Mhm.
it's actually overcoding
Oh.
the encounter because it's picking up on these words that the physician knows is just in the background, right? But it's picking up on every word. And so it's a really different, environment.
Mhm.
Um, so that's going to be important, for physicians to actually look at it and make sure that they're not overcharging or that they're not charging wrongly. So
Mhm.
we've still got a ways to work on things like that. But I think that we're going to find that many of the things that are crucial to decision making, both on the part of the patient and they call them patients. Patient is someone who's sick, so I kind of resist that notion. I
Mhm.
prefer to look at everybody as well until they are sick.
Yeah.
But I think that there's going to be an expansion of the use of AI by individuals
Mhm.
because it's convenient. There's so much friction in our system in the US, and I
Mhm.
think around the world this is true, actually,
Yeah.
from what I've read. And that is that, there's just a lot of difficulty in using healthcare. And to the extent that we can take that out of the equation,
Mhm.
I think it gives you more immediate and better health, and you can ask it things that you may not wait for 3 months to go into your doctor and remember to mention.
Yeah.
Do you know what I mean? Which is what a lot of people are faced with. I tell everybody, you should have AI, you should use it, you should
Yeah.
learn it. You'll know if you're talking about yourself or your domain of expertise in your work. You're gonna start to see when it's accurate, when it's not. How do you work with it, you know? And I think that's gonna give people a better idea of what's really possible with it, you know?
Uh-huh. So just going back to the social determinants for a minute. One of those is loneliness.
Yeah,
A lot more people are lonely nowadays
yeah,
than we used to be. There used to be societal structures in place where people could go, and there are still a lot of work done to avoid loneliness with especially elderly people.
right,
Um, what role do you think technology can play there? And what role do you think AI can play there?
yeah. First of all, connection, and especially as people become older,
Mhm.
connection gets to be more difficult, right? I mean, you know, you get to an age where you start to lose your friends.
Mhm.
So the connection that you've always had is evaporates. You learn that people are super vulnerable when they're lonely, and that's a danger. So, I think loneliness is hard. Now, I've told stories in my book, Dr. AI,
Mhm.
Reimagining Healthcare. I've told stories about this, about like a single mother facing a situation with a child that they have or their own health and really not having anyone to be frank with, where they can really be frank. And I think I give an example where she realizes that she has this tool that she can use in AI,
Mhm.
and she starts this conversation. And over time, the AI helps her to get resources,
Mhm.
understand what's gonna happen, um, and it's on demand. If she's having a hard day at work
Yeah.
and she wants to know what could be my strategy around this situation,
Mhm.
she can ask ChatGPT or Claude or Gemini or any of these things.
Mhm.
And once she gets a kind of a rapport established, she can ask, and the context is there. the context of her role, her
Yeah.
job, what she's capable of. And I think it opens a lot of doors for self-learning,
Mhm.
self-improvement, and for companionship. Not that it's a good substitute for people, because people laugh.
Mhm.
Every once in a while, I'll get one of the AIs that I'm working with. I work with a lot of them.
Uh-huh.
I get one and I'll say, "Tell me a joke," and there's
Uh-huh.
still like a dot, dot, dot,
Yeah, yeah.
and it's like, and then it comes back
There's no
something like,
humor.
"From what comedian?"
Mm,
Give me a comedian, I'll give
mm.
you a joke.
Okay.
You still have to have the comedian, and, that's kind of one of my messages to a lot of my colleagues, honestly. You still have to have the comedian. You know what I mean?
Yeah.
Comedy is of its own art. It's kind of like you're doing improv all day when you talk to AI. It's an improv situation, so you have to be grounded and make sure that you're getting enough human interaction. I actually think that AI may have the ability to connect people better. Like if you play, let's say that you are interested in embroidery
Mhm.
or bridge. And you're like, "Look, I'd like to go out and play bridge with humans, but I don't feel good enough at my bridge to do that."
Mhm.
You can get a few lessons, then you can get pointed to a group, you can go
Mhm.
join the group. I mean, this is how it probably is gonna really work. I think every time we make a human connection and we feel confident in that situation, it's gonna have a lot to do with the prep that you can get
Mhm.
and the mindset you can have if you're working with an AI, an intelligence.
I want to switch gears a bit towards
Okay.
the solution. Uh,
Mm.
Healthcare or Health 4.0. You
Yeah.
developed the Health 4.0 framework. Um, what is it?
So here's the formal definition. Health
Okay.
4.0 is healthcare redesigned around continuous, personalized, AI-enabled health. Rather than episodic disease treatment, it asks, what would the system look like if we rewarded people and organizations for keeping people well,
Mhm.
not just treating them after they become sick? So that's its whole thing. It has 5 pillars. The first we talked about, aligned incentives
Mhm.
between all the people that pay for health, have continuity in health,
Mhm.
focus on prevention, focus on outcomes. That's all very different than what we do in our country right now.
Mhm.
Continuously measuring using data to understand risk as early as we can.
Mhm.
Personalizing care, so offering tailored treatment to the individual.
Mhm.
And prevention for the individual, helping them understand what they can do today to prevent being really sick tomorrow.
Yeah.
Um, Really going deep on cultural and regional design, creating these islands or pools, if you will, where people who share culture, place, food, housing, all of that really start to help each other stay healthy, creating communities of health across the nation. And then AI that really is focused on connecting the individual
Mhm.
with the system to enable them to use the system optimally. So that's kind of the way that I see how the healthcare system could be really different than it is now.
Yeah.
Parts of that are also applicable, as I mentioned, to the global south, to uh, other countries that are struggling with the friction in their
Mhm.
own systems. I think it can be really helpful.
Yeah, I think most of it, especially the prevention part and the community part, can pretty much apply everywhere.
Yeah,
Because I
I
think
think
that
so.
if you have,
And it's exciting that we might have, imagine having a, a truly global network of health
Mhm.
and how impactful that could be for everyone across the world who's wanting to improve themselves or be healthy for a life, solve some of the problems that others have solved before them. There's a lot of of real value there.
Yeah.
I group that value under health because I think it is really health. You know, y in fact, on the platform we've developed, Wallet RX is one of
Uh,
the things. It's financial health. Like, how do I create financial well-being for
uh-huh.
myself and my family? That's not something we've ever really talked about, right? It's just been haphazard, and it's very culturally driven. So for women, in particular, to the point of your title, for women in particular, it's we kind of got left out of that part of understanding that part.
Uh-huh.
We've come to it just in the last, 4 or 5 decades, probably. And I mean, don't get me wrong, women have been disrupting industries for a long time, and
Uh-huh.
sometimes surprising to find those stories, right? When you when you find this story about this and you're like, "Oh, I
No,
didn't even know about that," right?
no.
Because we never really have talked or like you're doing, bringing attention and focus to it. I think it's really superb.
And fun.
Yeah, and fun.
Yeah, that it's a lot of fun to do. But
Yeah,
thank you.
that's good.
How do we? Because one of the interesting changes here is the shift from let's say crisis management to prevention.
Yeah.
Uh, but all the incentives currently are on the crisis management side. How do we shift that? What does it take?
Yeah, so in the United States, the reason that we don't pay for prevention is
Hmm.
because healthcare payment is guarded by a proprietary, personally owned group
Hmm.
called the American Medical Association, and it didn't arrive as a skullduggery or anything underhanded at all. What happened was when the government got into healthcare and Medicare, and they needed a way to value services, so
Hmm.
they went to the AMA, which was, the big right there at that time, I think they represented about 80% of the physicians in the
Hmm.
country, and they said, "How should we do this?" And they came up with this idea of relative value units.
Hmm.
So they could relate doing a cholecystectomy, taking out the gallbladder,
Hmm.
or doing brain surgery, or seeing a person in the clinic. They valued all those things.
Hmm.
Now, what that did is it pushed the reimbursement to the side of intervention. And everybody has their hand out for it. So if you do a gallbladder operation, you might get 150 relative value units.
Hmm.
If you see a patient in the office, you might get 10. Over time, there's no incentive to see a patient in the office,
No, so
right?
instead, actually advising people on what they should do to prevent the surgery is less rewarded than
Doing it.
yeah,
Yeah.
and probably for the simple reason that the surgery takes a lot more material, lot more knowledge. There's a whole, literally a theater built for it.
Yes, literally. And the thing is that when you think about it, the 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 growth of the structures, the hospitals, the hospital systems, the competition to get the gallbladder surgery and the heart surgery and the transplant surgery done in your facility.
Hmm.
Every time you add complexity, you add money for reimbursement. So there's no incentive to prevent brain cancer.
Ah,
There's only
because you're
incentive to
paid
pay
for the.
for it to be fixed. And so that system, and you're paying it for it by pieces.
Hmm.
So what that means is the primary care physician who first sees you and you say, I have this problem with my thinking or whatever you're doing, and then they refer you to a specialist who refers you to another person. So you've got now all these very specialized, highly paid people involved. You get a hospital involved. You get the
Hmm.
hospital radiology system involved. All of a sudden, this small thing that could have been caught up here
Yeah.
is being treated with surgery usually and chemotherapy and, all kinds of other things.
Yeah.
So that is going to continue as long as we reward the system in the way we do. So getting to a place where we're paying for continuity and health rather
Huh?
than rescue is it's necessary. The big, as always, it's the details are going to be really important. Health 4.0 will
Mhm.
facilitate the system the way it works. It'll connect everything. But there has to be a mechanism by which we establish a new view of what we're going to pay for and how.
Mhm.
We're still going to cover rescue. We're going to have to cover rescue until we can bring everything upstream far enough, right?
Yeah.
That health is the expectation. You live your whole life in health,
Yeah.
and you avoid rescue if you can, you know? That mindset shift is massive. For the system, it means complete revamping of the education that we do for people,
Uh-huh.
the way that we regard food. Food almost should be a medical treatment, honestly, because it's, essentially the one signal that you get all day long is food, right?
Yeah.
Uh,
How do we change these incentives? What is needed for surgery for surgeons? Now, let me just ask before we go here: is this a zero-sum game in the sense that what when you start rewarding, let's say, prevention and advice upfront more, does that come at the expense of the surgery part?
Yep. And that's that example that I gave you, the
Huh?
GLP-1 versus surgery and
Yeah.
how much surgery has dropped. That has big implications for the system.
Huh?
Bariatric surgery, at least at the time that I left the OR 5 years ago, was about 25 or more percent of all the surgery done in a hospital.
And bariatric surgery, what is that? Just
That's
for people who don't know.
that's a set of operations that changes the way that you process food, and
Uh-huh.
the change in the way you process food
Uh-huh.
changes your weight. The weight loss creates a value in avoiding diabetes or making your diabetes much better. In fact, the reason I started doing those procedures was
Uh-huh.
because I operated on a diabetic patient who went home without medications and never went on them again. I mean, I the idea you could do a surgery that cured diabetes just blew my mind. Well, now we've
Uh-huh.
got GLP-1s, which can have the same effect of improving diabetes altogether
Yeah.
without the risk of surgery. And so even though we've got the risk down and it's very small, it's still not zero.
No.
And if you're a woman with 3 kids, right, you don't wanna put your family at risk that way. So, I think that you're gonna see this happening. This is gonna happen normally
Uh-huh.
because we are inventing the future.
Uh-huh.
There's for instance, in the cancer work, I was a surgical oncologist before I did bariatrics. And
Uh-huh.
in that work, we've got tools that can destroy a tumor
Uh-huh.
by ultrasound rays, focused ultrasound.
Uh-huh.
No chemo, no needles, no surgery.
Uh-huh.
That's 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 upstream, right?
Yeah.
From having a surgery, staying overnight. It's a day procedure. You walk in and a half hour later you walk out without the lesion.
Uh-huh.
So we've got blood tests that can detect cancer very early.
Uh-huh.
We can create vaccines. We're starting to get this technology movement. It's not just AI,
Uh-huh.
but it's the whole of that technology movement. And now people are starting to use the tools to help them design the answers.
Uh-huh.
So, this is going to be very fast now, I think. So catching up with that, after thinking about it a lot, I decided that it would be unlikely for a
Right.
government to be able to move at speed on this. There's a lot of barriers. And so I thought, well, let's take the healthcare system private altogether, but let's formulate it in a very specific way. So the company, the operations, is all done through a company that has a public benefit corporation structure. So, that's an established structure with a separate board of directors. It's overseen by a trust, which is meant to be a continuous funding mechanism for health. And so, and it's going to require substantial funds. In the United States, I identified 1,000 people who could fund the entire thing in a year if they wanted to. That's how we have the capability of funding that. And then it's an established mechanism to generate more funds from the fund itself.
Yeah.
And then that starts to pay for this. But there's something I call the health trajectory benefit. There's a benefit to families and companies if we are all in the same system of health. If we all have comprehensive health care for rescue, but what I call pulse or proactive care, if we have those and we can use that proactive care and we actually have health, that creates like a financial benefit. For an employer, if they all come in the system, including the government, if everybody comes in the system, that frees up hundreds of millions of dollars in the financial system to be used to change their industries into tech forward. So there's a lot of benefit here. And I'm in the process of completing the arc of articulating it and building it. So the trust is, they're all chartered now. And, we're getting started, down this route.
Yeah.
So.
And the trusts are a bit like what the NHS does in the UK? Not sure if you're familiar.
Yeah. The NHS, but it's in fact, I really would love to work with the NHS using this system because it can take that middle friction out that's hurting them so much, and it can take a lot of pressure off their healthcare workforce, which would help a lot. So, I think there's a way for this to be helpful to most countries.
Yeah, for sure.
So, yeah.
How important is data? And the reason I ask this is two ways. One, to have good AI, you need good data. That's sort of obvious, but I spoke to Ida Tin. She's the co-founder of Glue a while back, and she said, well, for women's health, there's an additional problem, being that we don't have the data sets.
Yeah.
So how can we fix that part? Because I think the technology itself is there. My read from it is that in part trust is not there for the women to use it. At least here in the Netherlands, it's changing a bit now, I have to say. A lot of women are still, and I was even overhearing a conversation in the train the other night, to young women talking to each other, well, I'm not going to use AI for my work because then it knows everything about me and I don't want to trust it with my secrets. So there's still a lot of distrust on the user side, let's say, but I think it's needed, that body of data.
It is. It is needed. We really are at terrible disadvantage in the United States because our data set is really flawed, and it's flawed in part because of the way we collect it. It's flawed because not only do we use outmoded ways to do it, but we haven't ever really had, because of these 50 different states insurance plans, we haven't really had a unified data set that could be impactful in this way. So we're going to have to build one. So in the structure of Health 4.0, there's a set of things. First of all, the design is that all the systems for data are federated systems. So that gives you, that security piece. The second is that, so local regions have their own data. They keep all the data. They can lend out some of it if they want to. The person whose data it is has the complete control over that. But the other thing is that we'll start to get data, and data's going to be complex. It's really complex. That's one of our problems with it, right? And what we've had to do in the past is we've had to dumb it down to non-representative samples of disease, narrow windows of treatments, because we didn't have a way to actually use data in volume, right? Which we do now.
Yeah.
Have it. And so we can be a lot more precise to the individual, but also beneficial to the community at the same time. It's a very rare moment, I think, in healthcare, and in humanities, history. It's a really rare moment. So it's exciting. It's scary. It's why we have that board of trustees to ensure that the PBC is doing its work with good intent and in behalf of all the people that are involved in the system.
Yeah.
Eventually, my hope is that we could have a data lake where we have a federated data system, so the data is with the people, but we have a data lake that can be utilized to help populations from all over the world.
Yeah.
That would be ideal.
Okay. Can I just ask you something that isn't in the script, but Senator Bernie Sanders, I think 2 weeks ago or so, as of the date of the recording, he proposed to sort of quote unquote seize 50% of the equity of all the AI companies and use the proceeds to generate a sort of universal basic income, a dividend he calls it, that people would receive as a compensation for their data.
Yeah.
How could that play into your initiative, or would it actually counter?
I think Senator Sanders has been committed for his entire career to equity. And I think he's trying to reach for a good equity solution there. There's, people, when I talk about healthcare, people say, Robin, the healthcare system's so huge and complex, it can't be changed. And I'm like, no, it can be changed. It's going to be changed. The question is whether we're going to guide the change or not. And a little bit, I think that the senator's trying to guide the change. He's trying to say, how do we fix this? But once you monetize the data use, it has a lot of repercussions that I'm not sure that his colleagues in the Senate or the House will appreciate, or even the American public, a large part of them. I kind of fall on the side that which has been a tradition, and that is, if I want to give you permission to use something, then you and I decide if I can just give you that something or not. I was listening to a really important talk the other day by one of the people from Seattle, and he said something really important to me, and I still have a little bit of work to do, actually a lot of work to do to try to really, suss this out. But he said, we're beyond the need for data. That was the problem we had 10 years ago and 5 years ago. We can synthesize data. We can create digital silicon data that we can create digital twins. This is far more powerful because it's a contained it's a controlled environment.
Yeah.
And he said, so data is not what we want from you. We're looking for context.
But context comes also in this form of data, I would say.
Maybe. But in some ways, it's me interpreting the context. It's me setting the context and making decisions within the context. That's the part, the inference that AI really needs to be better at its job. It was a very interesting statement, and I think deserves some work. Like, I think pushing on that and getting to that nuance, because it's really important for decision making, like on a board level. It's important to understand if you protect all of your data, but the inference of the decision making is still visible. That may have been the asset.
Yeah. Yeah, but that's where, going back to your example for the single mother using AI to sort of coach her, can come in.
Yeah. And that's what is happening there, is her making those decisions within the context of her situation, demonstrating how a human does that, as imperfect as it can be. That's it. You can understand why an intelligence would want to really deeply understand. Once they have an idea of the way you make decisions, they could be much more helpful to you because they can help you, mitigate your downside, maximize your value, in a way. So it's an interesting time, is it not?
Yeah, it is. Just to go back to where we were in the conversation, you're attempting something like really ambitious. Changing healthcare is like you have to change a lot of things.
Yeah.
How did you decide where to get started?
So, in my life, there's always, places to start. I decided that I needed to flesh out. First of all, I needed to get the background that I needed. So, I treated patients, I led programs at the academic level, written academic books. I've worked as the medical director at Banner. I've been at J&J as a senior vice president for medical affairs. I'm like, I've seen the system very deeply. But when I came out of J&J, when I retired, I was like, I need more governance training. I need to understand governance. And the best place, I think, to understand governance that's 1,000 years old is in London. And so I went and did a very deep level 7 governance master's, essentially, with the Financial Times and Pearson. And it was really intense. And it included, behavior, financial statements, the whole bit. And then I did a bunch of work at MIT to get ready for the digital piece, because I wanted to really be able to understand digital technologies, sustainability. I've said often that longevity is the ultimate expression of a sustainability, right? And so I really was going deep in that. And I went to MIT and was able to get my certificate in that. And then I thought, okay, now I need to really do a deep dive in AI deeper. So I did that at Oxford. So once I had that framework, I started writing. Because to me, being able to express in words how the system should work, working that out on paper day after day, struggling to both express it to others, but understand it yourself, understand the edges. And I started to really slowly get my head around what would need to be changed, how it could be changed, when it could be changed, what are the conditions we need. And so that culminated in me publishing the book, which is Dr. AI, Reimagining Healthcare, Rebuilding Trust, Delivering Health 4.0, which it's funny because people are discovering it. It's, available everywhere, but people are discovering it and writing to me about reading it and thinking about their own situation and their role in the situation. Um, and I wrote a strategy that's based on the Overton window strategy, which is where you take something from being impossible to inevitable. And I have that strategy mapped out, and I'm working on doing it.
Yeah.
It's going to take a lot of people. There's, one of the things that I really wanted to say is that there's a lot of incumbents here, and their incumbencies are going to be disrupted. We've talked a little bit about that today. But I think you asked very specifically, you said, what would you say to these people?
Yeah.
What would you say to these different people?
Yeah.
And so I thought a lot about that, and I prepared actually an answer to that question because I think it's a very important question. And because each person's going to need to participate. So if I'm talking to a healthcare minister, right, I'm going to say start with national health goals and payment alignment. Decide what outcomes are going to matter for health, then fund the infrastructure to measure and improve them. So that gets to how you work to the structure of the system, right? For a hospital CEO, and I thought I should say, start by expanding your mission from beds filled to lives stabilized. To complete that whole arc, hospitals become hubs of regional health, not just centers of acute rescue. So that's a new way that they decide to participate in the system. And then for the CEO of the insurance company, right? Clearly one of the sticky wickets of this whole conversation, start paying for continuity, prevention, and risk reduction. If they want different outcomes, they're going to have to stop buying the same activity. Payment has to move there.
Yeah.
And, I personally think it's probably not appropriate to have a proprietary system of payment defined by 36 people in a closed room. I think that's probably not where we need to be as a country. And, things have changed since 1920. And probably we need to redesign the payment system to be more aligned with what our real goals are.
Okay, so talk to me about what we should change in terms of incentives for insurance CEOs here, because I think they are currently the least incentivized party to change because A, they have their legacy IT systems that everything needs to change. B, they have been educated, brought up, taught that it's all about the treatment, not about the prevention.
And their leadership is taking down massive, substantial amounts of money every year for doing that job.
Yeah.
So I think that what they need to really ask themselves seriously is, how do we finance more healthcare? Stop asking that. Stop asking how we finance more rescue, and start asking, how do we produce health? How do we as a company produce health as a mission? And that change in mindset can drive change. But the board of directors, which is why I studied the board situation so much, the board of directors is the place where that has to happen. And they have to be willing to it. Now, the problem is many of those companies may be companies that have shareholders. And in that scenario, they're beholden to serve those shareholders. That's why the alliance is not organized that way. It's not beholden to shareholders. It's a public benefit corporation. Its goal is to do what that requires. And that's a whole different scenario.
Yes, and do you then sort of foresee a shift from business going from individual insurance company to the alliance,
Yeah.
where you can actually sort of use that as if it starts to work as a lever for the insurance companies to change, because either they comply or they
Yeah.
quote
And
unquote die.
what I would for me, I think one of our keys is to get our Congress and our federal workers, the military, the veterans,
Mhm,
the people on Medicare and Medicaid, the
mhm,
employees. And I actually wrote, Dirkjan, a transition plan of how this comes up out of the water and
mhm,
how people start to roll in different phases.
mhm.
And at 10 years, the entire population is in a new health system.
In 10 years.
Yeah.
Yeah, yeah,
And
that
for
would be
many
really,
of
yeah,
them, it'll be the first time they've ever had healthcare insurance.
yeah,
You
yeah.
know, they've ever like had an expectation that they have health. So, there's going to be a lot of talk, negotiation, you know, work ahead.
Mhm.
And I'm going to keep after it and try to deliver it.
Yeah. Why? Why you?
I don't know why me. I don't know why. Um, but I will tell you how it felt
Hmm?
when you were a young surgeon and you walked up to somebody who
Mhm,
was clearly dying and said, I'm going to take you to the OR and I'm going to do everything I can to save your life.
mhm.
And for some reason, they said, let's do that. It's a tough decision to make for that person to trust you.
Mhm.
But I don't know. I somehow feel like everything I've ever done, all those people that I remember, um, put me here. So, I don't know if you ever know why that, but I have to try. And if I have enough people come to the banner
Mhm.
and understand what's trying to be done here,
Mhm.
I think we could make this happen. So I'm going to go out and ask them. That's all you can do, right?
Yeah. And
Ask them for help.
you already have, as we say in the Netherlands, you already have to know. So you might as well try to get the yes.
Exactly. Exactly. The nose demonstrated all day long. So, and I really feel really strongly that my colleagues
Huh?
need someone working on their behalf, really on their behalf,
Huh?
to fundamentally help them bridge to the next role they have, which is essential. It's essential not to lose that expertise and that commitment. But I don't see any organized group trying to do that other than saying, "Oh, no, wait, don't do that," and that's not gonna happen. It's AI is here, and
Yeah.
it's gonna get more powerful, period. So, we need to learn to govern it without hobbling it, and we need to give people back the autonomy over their own selves and their decision making,
Yeah. I think
and
that is
that's
what AI can also help to do indeed.
I know it can because I use it all the time, and
Yeah.
I know it can. So I really see these things as being really achievable, and I think if enough Americans want autonomy and they want to have good health, that we'll realize it. We're very powerful as a country when we come together for the right reasons,
Mhm.
and, I think this is one of them.
Cool.
So optimistic.
Yeah, no, but I think that's important also. The most entrepreneurs I talk to are and also very
Mm,
positive-minded and opportunistic people. They take chances if they see, and then even more so in the US actually than in Europe, where we're a bit more risk reverse, I would say, but
Mm,
they just take the chance and run with it and see where it gets them. So
yeah,
I always like it's one of the reasons for me also to do these episodes
yeah,
get my own sort of inspiration, so to say.
yeah, that's good. That's really
So
good.
yeah.
Well, it's a good thing because, every time you have an opportunity to talk about what you're doing,
Mhm.
um, it helps you clarify it, you go back over it, you recommit to all the things that brought you there.
Yeah.
You examine your own journey in some ways, you know?
Mhm.
And, I always have to get up in the morning and look in the mirror like everybody does and say, are you where you're supposed to be today? Are you
Yeah.
doing what you can? Um, so today's answer is yes.
Yeah.
I'm gonna try to do that every single day as long as I have them. And, what I'm finding is there's a lot of people being called to this banner.
Mhm.
I sit down and talk to people all the time, and I ran into a young woman who's 7 months pregnant, and she gave me an earful about the healthcare system.
Mhm.
And then we started talking about this idea, and she said, "Where do I sign?"
Mhm.
And I laughed and I said, "Well, it's not quite ready yet. It's
Yeah.
not quite ready for that, but, I think we can get here. I
Yeah.
really believe it.
Yeah.
We'll get everybody there."
Yeah. Eventually, you'll manage that,
Yeah.
I'm sure. Um, I just want to talk about something else you were working on, back to the AI theme, because you wrote a book, Doctor AI, but you're
Mhm.
also building a Doctor AI, I think.
Uh,
Can you give us a sneak peek into what that is and how it fits into the Health 4.0 framework?
yeah. So, I think it's important to have a demonstration of what this can be, that people can look at and hold and
Huh?
use. So, I was one of the people that purchased the DGX Spark
Huh?
from NVIDIA.
Huh?
The very founder, it's a founder's edition from the factory. And, we're working on what I think the agentic system looks like that can support this. So it's very exciting. Um, the MVP will be coming forward soon,
Huh?
and then we've got a group of people. When I wrote Doctor AI, I had 30 beta readers,
Huh?
and I would send out a chapter or something to them, and they
Huh?
would give me this amazing feedback. And it was very diverse group.
Huh?
Um, People in their 70s, people with kids, people who weren't vaccinating their kids. Like,
Huh?
it was very, different spectrums of the thing. Because this is not, health is one of those great levelers, right?
Huh?
It respects not income, it doesn't respect your intelligence, it doesn't respect your anything. It
No.
just comes. And
Yeah.
so it is true in our country that the 1% can access anything in health they want, and they always will be able to. So
Huh?
I'm not worried about them. I'm worried about the 99%. Those are the people that I really want to get good health care for.
Huh?
And so, yeah, so we're getting there. It's coming, and
Yeah.
the trust is up, and people can donate to it, which is great. It's tax deductible. It's a public charity, established as such.
Huh?
Um, we're starting to think about people.
Huh?
CEO for the PBC for the H4 Alliance,
Huh?
and
So it's basically, if I understand it correctly, Doctor AI, the
the
AI
book.
part. There's
Mhm.
the book and there's the AI part. That's a sort of health agent
Oh,
for people.
yeah,
Or,
it might be described that way. I think the description will be written by the people that use it, actually, but it's gonna connect the system together, which will be great.
well, the invitation is already out there to come back when the MVP is live. So we'll have more about what it is and how it works in
Yeah,
practice.
yeah, when we've got to that point. But,
Yeah.
the thing is that, it's absolutely fascinating to do the work. The other day I made a new website, robinblackstone.com, and I made the whole thing on WordPress. Something that myself with the help of Claude and ChatGPT. And it was such an amazing experience. And now there's things that I can do that I couldn't do 3 weeks ago. And I know a lot more about how all this system is connected with websites. So, this is a tremendous educational tool that we have.
Yeah.
And I'm just enjoying the heck out of it. Like, I get up excited.
Yeah.
This morning I woke up at 2 and I was like, get up. My brain was like, get up. And I thought, no, I've got an interview today. I better not do that. But, I've been an early riser most of my life, so that's been to my benefit.
Yeah.
Anyways, and I truly, actually, it's so humbling to care for other people as your work.
Yeah.
To me, this is really dear. Like, I really want this to be, for people, a much better answer and a more fair answer for health than we've ever had. And I think we can do that. If I didn't believe it, I wouldn't be trying.
Yeah. That sounds like a great place to close. I have 2 questions left.
Okay.
One goes back to your point that you made earlier about connecting people better. So I'm building an AI coach for founders. In health, but also outside more the tech part. To be honest, to connect female founders and investors, actually to connect them better than they are currently connected. From your perspective, what is essential so that this tool can support female founders in health tech, or how could it support you in getting funding?
So, I gave this some thought. I think for female founders in health tech, everybody knows about a polished pitch deck. I don't have one yet, actually, between us, but that's something that I'm working actively with a group of people that support this project to do that. But I think it needs to help them translate the clinical insights they have into investor language. It's not something that comes as easily to us. A lot of times we didn't really do that, much of that. But specifically around, market size, evidence, reimbursement, all the things that are very mundane to other people, but need to be really figured out. And I'm encountering a lot of them. The regulatory pathways. The other day I was sitting at coffee and I said to one of my coffee buddies, because there's a group of 10 of us that sit down in the mornings and have coffee together at 6:15 in the morning. Yeah. And so I'm sitting there, and she and her husband are both teachers, and they're both part of the unions. And so I'm telling her about what I'm doing, and we talk about it all the time. And she said, I've been thinking a lot about that. The unions have made their mark on getting better health care for the people that belong to the union. Health care and pensions. She goes, that's their bread and butter. She goes, so when it comes to health care, you're going to want to really talk with them and get them on board and get them aligned. And I said, they can keep the pensions. I'll take the health care. She just started laughing, and she goes, anyone else said that, I would not believe it. But you? I'm like, okay, she probably can do that. Yeah. But, there's a lot of those little hidden pockets of influence and, if you can help us understand that and flesh that out and be a person who can be a good early person to talk to, I think it's super helpful. I lived in one of the things that I'm probably best at is risk. Like, I understand risk in a way that many don't, like in a real way, like death or not death. But I think understanding business risks, the breadth of them, the depth of them, without being overly cautious, Because, and I know that the stuff that founders work on is new.
Mhm.
And by definition, they're charting new paths, hopefully.
Yeah.
If they're doing something meaningful, that's probably true. The other thing is, I find this on the board level a lot. Um, I ask different questions than other people ask. And I don't know if that has to do with being a woman or just the way my mind works around
Mhm.
problem statements, but there may be actual differences between the way women think about risk and the way men do.
Oh, yeah.
Um, and, I think you see it play out right now on the international stage. Women are more likely to say, unless it's a really serious issue,
Mhm.
like threatening the world,
Mhm.
wouldn't it be better to inherit a country with intact groceries, schools, hospitals,
Mhm.
and social infrastructure? Isn't that better than bombing the heck out of something?
Yeah.
Like, I'm just asking,
Yeah.
and I mean, that's something we would value because we value the work that goes into creating those communities a
Yeah.
lot. So I think there's some really big differences between women and men in this field, and probably you'll be good at doing that. I have a young mentee who's really a superstar, and she has a project that's gonna really be impactful in surgery, and,
Mhm.
I don't know, when she asks questions, I just stand back amazed at the level of sophistication
Mhm.
and the 360-ish-ness of it,
Mhm.
and, it's a joy to work with her. I'm very lucky.
Yeah, and it's at least that's my experience, personal experience as well. To be able to pay it forward is always
Yeah,
like,
and, thanks for the questions.
oh,
It
welcome.
helps me to be better at what I'm
Yeah.
trying to do, and I appreciate that.
Well, that's the whole purpose of the interview, but also of the funding coach, to help people be better and be connected better. So,
Yeah, it's great.
Dr. Robin Blackstone, thank you very much for a truly amazing interview. Really enjoyed this. Almost 1.5 hours. If
Wow.
Yeah, if people would like to learn more about you, about Health 4.0, and about your book, Dr. AI, and maybe also follow you to see what is happening to the Dr. AI initiative, where would you like to send them?
Probably to my website is the best place.
Okay, so that's robinblackstone.com.
Yep, pretty
Cool.
simple.
Yeah.
Thank
Okay.
you.
And we'll send people there. So
Okay,
the links
thank
are
you.
in the show notes. Once again, thank you very much for a great
Thank you for
interview.
having me.
And listeners, thank you very much for listening. And until the next episode, as always, keep being awesome.
Keep being awesome.
Well, that's a wrap. Thank you for listening to episode 163 of Women Disrupting Tech, titled Health 4.0, Transforming Healthcare for Real Health Equity with Dr. Robin Blackstone. Dr. Blackstone and I hope you found our conversation as interesting and transformative as we intended it to be. And if you have any questions for Dr. Blackstone, please leave them in the comment section on Spotify, YouTube, and/or Apple Podcasts. You can also use the comments to suggest guests that I should interview on the show. If you want to connect with Dr. Blackstone or learn more about her Health 4.0 initiative, please check out the links in the show notes. As usual, you can find the show notes at womendisruptingtech.blog and on my Substack via the links in the caption. There you can also find the links to Dr. Blackstone's book Dr. AI and the link to my new fundingcoach.ai tool. If you found this episode useful, please take a moment to rate and review the show on Spotify, Apple Podcasts, or YouTube. And if you don't follow us yet, please hit the follow or subscribe button so you never miss a future episode. Every week, you'll hear how another founder or investor is working to close the funding gap, one conversation at a time. Once again, thank you for listening. I hope to see you in the next episode, and until then, as always, keep being awesome.